Mesdames et messieurs les représentants du ministère de la Santé israélien, monsieur le docteur Richard Prasquier, monsieur le docteur Georges-Fabrice Blum, représentant de l'AMIF, monsieur le professeur Emmanuel Messas, représentant d'Adassa France, chers participants, chères participantes, je suis ravi d'être ici avec vous. Je suis le docteur Alexis Astruc, trésorier de l'AMIF, médecin généraliste. Je travaille au centre Et la Santé à Paris, qui est un centre ambulatoire Covid-19 pendant toute la période. Et c'est un véritable honneur pour moi d'animer cet événement international avec de tels intervenants. Je vais rapidement laisser la parole, car mon rôle sera strictement limité à de l'animation, notamment pendant la partie questions-réponses. Et le docteur Richard Prasquier, président d'honneur du CRIF, du Keren Hayessod et de l'AMIF, sera le modérateur. Ladies and gentlemen, representative of Israeli Ministry of Health, Dr. Richard Prasquier, Dr. Georges-Fabrice Blum, representative of AMIF, Dr. Professor Emmanuel Messas, representative of Adassa. Dear participants, I'm delighted to be here with you. I'm Dr. Alexis Astruc, AMIF Treasurer, General Practitioner. I work on La Santé Health Center in Paris, which is to host this international event with such speaker. My role in this event is very simple. I will only organize speeches. I will collect your questions to make sure that they are transmitted to the speaker. The speech will be in English, but there will be some translation in French as that everyone can follow this properly. I will immediately give the presentation to Dr. Richard Prasquier, who is the moderator during the session. Richard, it's your turn.
Merci Alexis. Je vais dire quelques mots en français et je voudrais que tous les participants sachent que nous sommes très heureux et très fiers de ce webinaire. Il sera en anglais. Je vais faire après chacune des interventions un très bref résumé français de l'intervention de façon à ce que ceux qui ne maîtrisent pas parfaitement l'anglais puissent suivre. Ensuite, vous pourrez poser des questions et Alexis Astruc va vous donner la parole après les interventions. Nous avons voulu faire ce séminaire parce que avant le déconfinement en France, il nous paraissait particulièrement important de savoir comment les Israéliens avaient travaillé, quels avaient été leurs succès. On sait que leur taux de mortalité est particulièrement faible et quelles avaient été également leurs inquiétudes et comment se passait le début de leur déconfinement. Alors je laisserai tout de suite la parole aux intervenants et je vais dire quelques mots à nos amis israéliens en anglais et ensuite je laisserai la parole au docteur Georges-Fabrice Blum qui va nous exposer la situation en France telle que nous l'avons vécue pour l'expliquer aux Israéliens et puis ensuite le professeur Emmanuel Messas nous parlera de la situation telle qu'il l'a connue à l'hôpital Georges Pompidou. Et ensuite, ce sera le temps des Israéliens. My dear friends, I just said some word to the French public. This will be your speeches will be given in English. I will try to translate I will try to summarize very rapidly at the end of each talk in order that if some people don't understand quite well English, that they can follow the discussion. The first speaker will be Dr. Georges-Fabrice Blum, who will explain to you what is the situation in France, where we are before the beginning of the deconfinement. There are some concerns about the availability of masks and so on, and he will explain to you what happened in France during these last 2 months. Georges Fabrice, à toi.
Thank you very much, everybody. Thank you, Richard, for your explanation. I just want to present me. I am the Vice-President of AMIF. AMIF is the only association of doctors in France. We are 5,000 people, and we worked a lot in this crisis for the Jewish community. I have another function. I am a obstetrician and gynecologist, but I am also the special health advisor to a member of parliament in the east part of France, in Alsace, who called Olivier Becht. And we began the problem, the crisis of this COVID-19 began in Alsace, in the east part of France, near Switzerland and in Germany, the begin of the March, because we had a big meeting, an evangelist meeting on the 14th of February in Mulhouse, and it began quite 15 days after. And in the beginning of March, we saw a lot of people who had disease, respiratory disease, and after, you know, everybody can know that the crisis was in all France. In this moment in France, we have, 67 million people. In Israel, only 9 million people. And in France, we had 137,000 people who had the COVID. We had a lot of deaths, 26,000 people who are dead. And we have also 54,000 people who are cured. In Israel, if you want to compare, you had, 16,000 people who had COVID-19, 500 who were cured, and only 238 people who are died. So you know what is the difference? It's terrible. Difference is really significant. At this moment, we had also 278 persons with deaths yesterday in 24 hours. So it's a lot of people. More than you, in one day we have more than you in all the crises. But no, the crisis will finish for the first period. If you compare the number of people who are in the hospital, it's less 3.2% less. In intensive care, it's less 8% less. So it's a nice concept yet that the crisis will finish, or I think so, in the first period. And I would say, Richard Pasquier, we are going to be going back to normal deconfinement in some days. It will be the 11th May. So yet we thought that the crisis will finish. I hope it was finished for the end. But we had a lot of problem also, that we have 3 areas in France. One area is red, one area is yellow, and one area is green. If you want to imagine, the red part of France is the east part and Paris, and the yellow is the center of France, and the green part is west part, east part, and the north of France. So we are afraid to be a second wave, and we are not really prepared. You saw that we were not prepared for the first wave. We have no mask, we have no test. We have a lot of problem with the administration, because the administration is very low in France, and that's it's a red tape bureaucratic administration, So I think that we must change this method to work with the administration. You have a lot of less of deaf people in Israel, because you test, you isolate, and you treat. And we have no test in the beginning. We have not where to treat. We have only isolate all the country, but we have 26,000 deaf people. And if we don't want to have a second wave, we must respect the barrier measure that is social in distance, wearing mask, wash hand or with spoon or with hydroalcoholic gel, or no kiss, no handshakes, and no meeting. And it can be some problem with the Jewish community, because we have some fest. We had Purim before, and we hope that we cannot have a second wave in the Jewish community. We have a lot of people in our community where we will we would be also contaminated by the virus. And we hope that it can not have a second wave if we respect the barrier measures. So what is the situation now in France? Allô?
Oui, oh, merci Georges-Fabrice. Je vais donc Georges-Fabrice Blum a donc expliqué aux Israéliens la situation en France. Vous la connaissez tous, avec les difficultés que nous avons eues, 26 000 morts en France, environ 250 morts en Israël, donc une différence de 1 à 100 alors que la différence de population est de 1 à 10. Et les problèmes que nous avons eus, problèmes administratifs, problèmes de masques, problèmes de tests, tout cela vous le connaissez très bien. Je vais maintenant laisser la parole à Emmanuel Messas, au professeur Emmanuel Messas, qui va nous donner, disons, en quelques minutes, l'état d'esprit du clinicien qu'il est, qui a vécu cette crise dans un grand hôpital parisien, l'hôpital Georges Pompidou. Emmanuel, à toi de parler.
Merci. So I'm going to speak in English now, yes?
Yes.
Okay. So welcome everyone. So I am introduce myself. I am the head of Hadassah France and the head of Department of Vascular Medicine in the big cardiovascular department in Hôpital Européen Georges Pompidou. It is a hospital of more than 700 beds, mostly with a big cardiovascular department and cancerology department. We are not prepared at all for infectious disease or epidemia. We have a big ER department, but we don't have this knowledge about virus or infection. So we have to face this huge epidemic during middle of March to now. We completely reorganize the hospital COVID-oriented. So all the patients came to the ER. My department was a selection department. So they come to the ER, they don't have yet the diagnosis. They come to our department and we have the diagnosis, COVID plus, COVID negative. And if you are COVID plus, we are dispatched in all departments dedicated for COVID plus. We change the orthopedy department to COVID plus, the plastic surgery coming COVID plus, the half of the hospital became COVID plus, but we didn't dedicated a building for COVID plus or a building for COVID negative. We didn't dedicated physician for COVID plus and physician for COVID negative. We didn't test the physician, not once a week, even not once a month. We are only starting now for that. So we are not well prepared for that. We didn't have a high rate of infection in the physician. I think it's about 15% of the physician, and we lack nurses and physicians. So we have to redispatch all the nurses from regular department to the ICU, and we increase our number of ICU beds from 50 beds to 100 beds in 2 days. So we changed the CCU to ICU. We changed some, let's say, operating room to CCU. So it was not well prepared. It was a huge effort and very good solidarity between all the departments. We even bring the medical students to make them as nurses, to become nurses. And I have to congratulate all the universities, the medical universities that play a beautiful job, making the medical student part of the health work on the hospital. And sadly, we got some 15% of the medical students positive to COVID plus because they are not well prepared to this. Paradoxically, in the CCU and ICU, we have a very low rate of infection of COVID plus because the department is well organized for that. But in the COVID negative department, we have some positivity on the physician because they are not well prepared for that. It was at the beginning of the epidemic, we have a problem of mask and all of this, but now it's over. We have everything that what we have. And to be honest, now it's completely decreased. We have still 150% of occupation of ICU still, because as you know, the patients stay in ICU more than 2 weeks or 3 weeks. We have a mortality about 30% in ICU, and many patients came out from that. Now we are facing post-COVID complication. We see more and more neurologic states, or even dyspnea without any sign of pulmonary disease. So we are now investigate the post-COVID complication. In terms of research, we find out very early the problem of thrombosis, because we have here a department very specialized on thrombosis, and we have detect an increase of endothelial cell, circulating endothelial cell in the patient COVID plus versus COVID negative, and we advocate for curative anticoagulation very early for our patient, and we have submitted a trial on this. And we already, as all big institutions, part of all the big study, the one of discovery with hydroxychloroquine, with the antiviral medication. We're going to publish soon a study on the anti-IL-6 tocilizumab on very severe patients. And we are also working on stem cell and plasma, I think like in Israel. And also we are starting some study on the TMPRSS2 target trial on such a population. So we are now recovering now, and we are preparing for the two scenario end of May after the deconfinement. Either there is nothing happen and it's okay, but we are preparing for the second wave, and I hope that we'll be better prepared for this second wave end of May. I'm not convinced of that, but we are preparing to reopen a department dedicated to COVID, or to reopen bed for ICU. And
Emmanuel, on va. Je te remercie. Je suis obligé de te couper. Gardez le. Donc Emmanuel Messas nous a résumé l'histoire de Georges Pompidou, un hôpital qui n'était pas spécialisé dans l'infectieux, qui a dû en 48 heures passer de 50 lits de réanimation à 100 lits de réanimation, et qui a géré au mieux possible, avec l'aide d'un personnel médical et paramédical, une situation exceptionnellement difficile, et avec une particularité, c'est-à-dire la découverte très rapidement des problèmes de coagulation des patients qui avaient le Covid et des facteurs endothéliaux qui étaient sous-jacents. Voilà, je vais maintenant laisser la parole aux Israéliens, et je crois que la première...
Asher Salman.
C'est donc Asher Salman et qui va donner la parole, je pense, au docteur Emilia Anis.
Good afternoon. Can you hear me? So I'm sorry that my French is not good enough, although I'm a great admirer of your culture, and I'm basically in love in Paris. Actually, last December, just before the epidemic had started, I was attending the OECD meeting in Paris, and then I had a meeting at the Minister of Health here at your place, and I met actually the deans of the medical schools, Professor Friedlander, Professor Nerti, and of course Arnaud Monique. And we were discussing cooperation. And actually the first field of cooperation that we did discuss was infectious disease. None of us even thought that we are going to really find ourselves in a terrible pandemia just in 2 months' time. So actually yesterday, OECD had a big meeting about COVID-19, and I was presenting the Israeli side. And it was quite interesting to hear what other countries are doing. The next visit should be June. Unfortunately, I believe it will be a Zoom meeting rather than a physical meeting, but I promise to come. And I see Emmanuel Massas with his head. Well, being most of my career in Hadassah, I was very much in touch with Hadassah friends during the year, and have a very warm part of my heart with your organization. So back to business regarding COVID-19. we asked a group of experts from the ministry and outside to join us. So with me beside Dr. Osnat Luxemburg, the head of the technology directorate of the ministry, we have Dr. Boaz Lev, which is now the head of the epidemia management national team and the previous director general of Ministry of Health, and a long-lasting expert in this field. We have Dr. Roisinger from our public health directorate. We have with us Professor Ranir Paz, an expert in infectious disease from Hadassah Medical Center, and my team, which includes beside me Adam Cutler and Ari Zevrin. So as saying that, I would say that we are on one hand very much involved inside the country, and we have no time for any other business besides COVID-19, but at the same time, at least we are trying to keep in touch with what is happening all over the world, and to not only be informed, but rather to switch ideas, opinions, and to get new ideas how to tackle this major health and actually a social, I would say, event, maybe one of the biggest in our lifetime. At the same time, I think we in Israel had an advantage of being 2 or 3 weeks behind Europe. What helps us quite a lot to see what is happening in Europe and learn the lessons and try even and somehow modified our plans according to what is happening in your place. I would just say a few words. We had our first patient February 27th. We had our peak number at March 31st. We had started our, I would say, exit strategy April 19th with small steps. And we actually opened part of our education system just this Sunday. So we are slowly dropping out from the first wave. We are very much involved into the preparation of the second wave, God forbid if it happens. And there's many lessons to learn and to modify when we are planning maybe the second wave of this epidemic. So with no further note, I would give Dr. Roisinger from the Public Health Directorate to present the Israeli data.
I will just translate very rapidly. Donc, le docteur Salmon nous a présenté la situation israélienne très rapidement. Le premier patient le 27 février, le pic de l'épidémie le 23 mars, le commencement de la sortie, disons, vers le 19 avril, et la semaine dernière, dimanche, les jeunes enfants ont recommencé à aller à l'école, et actuellement, bien entendu, ils sont tous en train de se préparer à un événement dont ils espèrent qu'il n'aura pas lieu, c'est-à-dire la deuxième vague. Maintenant, il laisse la parole au docteur Emilia Anis.
Okay, thank you very much. Good afternoon. And I also apologize that I can't speak to you quite well enough in French. I'll have to speak in English. You see our slides, I understand. My name is Dr. Roisinger. I'm Deputy Director of Epidemiology within the Public Health Services of the Ministry of Health of Israel. And I'm going to tell you about our response, public health response for the most part, to the COVID event, and quite different from what we've heard from the colleagues as they walked in about the hospital aspect. We'll speak more about the public health aspect of things. So slide, please. And I'm going to describe our epidemiology, our policy, including border restrictions, lab capacity, social distancing, epidemiologic and investigations clusters, and all focusing on targeted individual isolation.
We don't hear you too well. So no. If you could talk to the microphone, it will be very helpful.
Okay. On the microphone now. Okay. So now you see, please, this is our epidemic curve. And you can see that we had first a rather exponential rise in cases, but leveling off in the last, I would say, 3 weeks. And we are now down to about less than 100 cases per week over the last, about a week, last week, less than 100 cases per week, more or less.
Still
already 50 cases a week. Am I being heard?
We don't hear well. There is a problem in the sound.
I can check that. 1 second. What's it? I'm not being heard.
We heard you very well, but there is some a bad noise, but we hear you.
Yeah, but there is too much noise around. Okay.
Roy, if it's still a problem, try to hook in through a cell phone. It would be much better.
Yes, it's better. The sound is better.
It sounds better now.
No, there is it resonates.
If it's complicated, let's continue. We won't disturb you. Maybe you are too far from microphone, I don't know.
Okay, we're trying. Is this better now?
Yes, it's perfect. Thank you.
Much
Oh,
better.
very good. Okay, so thank you for the technology assistance here. Okay, so now I see you, you see me, and we're all very happy. So this is our epidemic curve. As you can see, we had an exponential rise early on in the event. We were at a doubling time of about 5 days at some point, but now we are leveling off. And if you move your video slides, you'll see that we're down to, or we're having doubling time of 30 days now, so doing rather well. And you look at the new cases below, the pink down below is the new cases. We have about less than 100 cases per day for the last week. So we're doing rather well. And how do we arrive at this situation? This is, by the way, this is we have a dashboard which helps us navigate the health situation. And we see this every morning. Where do we stand? How many cases, new cases, how many in the hospital, how many severe, how many ventilated, how many recovered, etc. We have it all in front of us in real time, and we can get online and follow the situation online. So what is the policy that has helped us to reach this, I would say, rather good situation, at least up to date? Well, first of all, going back, yes. First of all, we were very cautious to notify all people entering Israel about the coronavirus and demanding a 14-day quarantine. This was early on in the event. Matter of fact, I came back from America, went right into 14-day quarantine, and really everybody comes back now is in quarantine. We don't have much travel now, but everyone who comes back is immediately put into quarantine without any questions asked for 14 days. We offer information for non-residents wishing to come to Israel. In fact, we denied entry for most non-residents. Only with special permission non-residents come visit Israel. We have Israelis returning from abroad and some exceptions, but in general, we don't allow foreigners into the country at this time. But we have information for those who do come in. We have a site where they can log in and get information. We have a questionnaire when you enter the country. At the airport, you land, you're required to get online with your smartphone and fill out this questionnaire, giving your passport, your ID, your name, where you will be staying in Israel, your contact details, and you are now taken right away to a quarantine. In the past, it was home quarantine, now it's hotel quarantine. The number of home isolations, you see we had a peak in mid-March, which was, of course, many people coming back from abroad, and also more contacts within Israel. But now, as we're controlling our borders and also controlling the contagion situation within Israel, the number of isolations is going down. We're now down to just 127 isolations started today. We have altogether in Iceland at the moment 2,500 people, but we had almost 200,000 people in isolation over the course of the event since early February. We're a small country, so that's a lot of people to be in isolation. Matter of fact, well, all country was in isolation, in lockdown for a while, but we were a lot of people in isolation. And the information is transmitted to the law enforcement agencies. Our police actually monitor the isolation, and people get tickets for leaving their isolation. If you left your house without authorization, you get a ticket. Lab capacity. We did our first lab test on January 24th, which is about, I guess, 2 weeks after we learned about the COVID event in China. But we expanded rapidly from February. We heard the pandemic announcement in March, mid-March, and we're now doing tests at 30, the number of 35 labs, actually based on today, 35 labs. We've done 400,000 tests so far, so we're at a very high level of testing on a national comparison level. And this is our number of tests. If you see that curve, don't confuse it with the case test. This is the testing curve. You say we were able to do 15,000 tests a day. I don't know how that translates compared to France per capita, but very high number of tests. And the number you see it's going down on the right to the slide is because there's less demand. We said we have fewer people coming back to Israel now, fewer contacts, fewer cases, less demand. People don't need the tests. So we're down to a few thousand, 5,000, 6,000, 7,000 tests a day, but we have the capacity of at least 15,000, probably 20,000 per day. And as we know, testing is a key to controlling the COVID, especially when coming out of the lockdown. We want to come out of lockdown, but be able to keep people in social distancing and immediately test suspected cases and quarantine their contacts. So testing is a key factor. I'm sure you all realize that. And this is the comparison of lab tests per population done to date, or this is done, I'm sorry, I guess a week ago, updated to April 24th. So we are right behind Lithuania, Estonia, and Portugal in number of tests per million population, and ahead of a number of our friendly European countries. Number of lab tests, what are we doing them on? You can see, interestingly, that many of the tests are recovery tests. In other words, our criteria for recovery are 2 negative tests after a positive test. And if you look at the timeline here, you see that going from left to right, the number of recovery tests increases because we're having more and more recovered cases and fewer new cases. So obviously the recovered tests are taking a more and more larger sample of our overall testing. And this is an interesting, hard to explain somewhat, but we looked at our data and found out that when at one point does a patient come back with 2 tests. And if you look at 17th day, this is a bell curve, of course, and the midpoint is met on 17th day. But in fact, if you want to catch most of your population negative, you'll only find them at 21st day, 25th day, 30th day. Only then will you find most of your people will turn out negative from 2 tests. And based on this slide, we've started testing people. First test after 12 days, second test after 15 days. And even so, we have many who are still positive even after that period. So it's we call it the long tail of our testing. Social distancing, well, I had my mask on before I took it off because we're allowed to, in video presentations in Israel, allowed to take it off. But social distancing, we were closing restaurants. The country was closed down for, I think, 3 weeks. Restaurants, malls, shops, workspace were closed except for necessary workers, which is Ministry of Health, police, fire, army, etc. You can imagine. We offered strict hygiene and sanitation instructions, 2 meters distance at workplaces and public places. We closed our parks, our beaches, our public gardens, all off limits. We restricted gatherings. Initially 5,000 people at a gathering, 2,000, and then now there are no gatherings. And now we're now coming back with 20 gatherings of 20 are allowed as of yesterday. But it was we were very strict, going down until no gatherings. Face mask wearing in public places and restrictions in public transportation. We almost closed our public transportation, not entirely. And we have when you enter work, those necessary workers have to measure their fever and declare their health status on entering work. And by the way, even in shops, when you go shopping now in town, and they say they have a thermometer, they say, well, how's your temperature? And have you been sick in the last few days? Have you had contact with a sick patient? So we're very, and hoping in this manner that we can go back to a relatively normal life, even without a full and total lockdown. And this is our public relations, stay home. The main message, stay home if you don't have to go out. And outside, well, you see that, wear a mask, keep 2 meters, wash your hands, don't go far from home, stay at home is the main message. It's very detailed, I'm not going to go into that, all these details on the left. Investigation of cases, it's a key issue. We have to be very quick in investigating our cases, because when you have a new case, if you don't find him quickly, he's going to infect other people. So we are very rapid. We have increased our nursing force 1,000%. We had in Israel 16 nurses doing investigations 2 months ago. We now have 170 nurses doing investigations, and it takes them an average 1.2 days to complete an investigation. We get the positive test within a day and a half. We know who that patient where he was, who we contact, and so we're very quick. We isolate positive cases either at home or in a hospital. We identify the contacts and quarantine them. We have a computer system which helps us to follow all these, because we have many investigations. And I'm sorry, I can't see my last, the blue on the right. I can't see it. It's hidden by my, I can't move it. I'm sorry. I'm missing what's a little blue on the right. I just can't read it. I'm sorry. I'll tell you if it's important. 1 second. Apologize. Okay, I will skip it. I'm sorry, I can't find it. Where are our cases infected? Well, that's in Hebrew. I'm sorry, I don't know how that happened. We got a Hebrew slide here, but the yellow, orange down below says contact with a patient. That's 65% of our patients. The light blue on the upper right is exposure abroad, 18%, and exposure in public places, 16%. And up on top, very small slices, public transportation, 1%, train, 0%. That's a few cases. So contact with a patient is the main exposure, although it changed over time. Initially, it was mostly coming back from abroad, and it's become more and more contact with the patient. This is a GIS, geological geographic information system. We have maps of all our cases, and this is a map of Bnei Brak, an Orthodox neighborhood or city with very high concentration of cases, and the colors are the concentration. The yellow is the most concentrated, the red is more concentrated, and the light blue or the gray is less concentrated cases. So we have maps of the whole country. We can see where our cases are in the country. So in summary, and I'm told I have 1 minute left, we were quick. I think Israel's in a good situation vis-a-vis the COVID, and I think due to our quick response, early border restrictions, rapid upgrade of test capacities, early and decisive social distancing, early case identification and isolation, broad-scale rapid epidemiological investigations, and clear and frequent guidelines, regulations, and legislation measures. Matter of fact, in law, orders for all our methods, all our steps. I hope that I've helped clarify things from Israel's perspective, public health at least, and thank you very much for allowing me to participate.
Très bien, alors merci Dr Roesinger. Le Dr Singer nous a expliqué les caractéristiques de la réponse israélienne au virus. Et donc, les éléments, c'est la fermeture des frontières, très rapidement. Les tests qui ont été effectués très vite. Le premier test a été effectué 24 janvier. Ils ont pu monter, ils sont capables de monter jusqu'à 20 000 tests par jour. Vous multipliez par 7, vous avez le cas en semaine et vous comparez avec la France, c'est assez impressionnant. Et de plus en plus aujourd'hui, les tests montrent que ce sont des tests qui reviennent négatifs chez des gens, des tests de finalement de guérison. Et ce qu'ils ont montré, c'est qu'on pouvait garder de virus, tout au moins avoir des tests positifs, ce qui n'est peut-être pas la même chose, pendant un temps souvent très long et qui peut dépasser les 15 jours, c'est-à-dire les 14 jours de quarantaine. Les investigations se font essentiellement par des infirmières spécialisées. Ils ont 170 infirmières dans le pays. Il leur faut à peu près un peu plus d'un jour pour investiguer les cas et ensuite ensuite ils repèrent les lieux où se sont passés les clusters, et notamment il a donné l'exemple de Bnei Brak, dont vous le savez, il y a eu une augmentation, une particulière fréquence des contaminations. Voilà, on va laisser peut-être la parole maintenant au prochain intervenant. Okay, now the floor is yours. Thank you. Who is the next speaker?
Dr. Boazlev.
Dr. Boazlev, qui est l'ancien directeur général.
Can you hear me well?
Yes. Well, good.
Okay. Well, it all started around the end of January when we had few patients stranded on this love boat on the Japanese coast. And it started to trickle, and we convened the Council on Epidemic Preparedness, which I'm heading, to start discussing what's going to happen. We had no idea. So as far as that, on the 24th of February, I went to Lapland. I had a good time there. And while I've been there, I convened about 4 times by telephone the council. And on the 25th of February, I called another friend who was in France doing skiing. And he's actually a mathematician. He's a modelist. He makes models, and his PhD is on models for epidemics. And I told him, listen, Amit, you have to make a model for this thing which is coming, because we have no idea what's going to happen. And we came back and we looked at the model that they did. We didn't have much data, so we had to make up some data. And we looked at it and we were horrified. So if this is going to happen, we are crashing in no time. And then we followed the model for a while, actually until today, which is leading some of our responses. And one of the things that we learned, and which is not my quotation, is that all models are wrong, and some are useful. So we use them as ways to next. Thank you. Thanks you. Right. Okay. Now I decided to concentrate on some of the riddles that this enigmatic virus poses to us, and how we are trying to solve some of these questions. One, obviously, is the immune response. Is it humoral? Is it cell-mediated? And I'm not telling you anything new. Obviously, we are looking at it by the laboratories. And the first thing that we wanted to know whether the antibodies that we are finding are neutralizing. So we in the Biological Institute in Israel are looking at, this is the facility where we can actually look at the virus, grow it on Vero cells, and see whether they are infecting the cells. So we're looking at various neutralizing antibodies, and actually they just came forward with some purifications, which they are saying they have now a monoclonal antibody which is neutralizing. So this is good news for us, and hopefully many other places are looking at these antibodies, and we may have something in our hand. Let's hope so. Now, the other question was, we didn't have any serology tests for a very long time. Actually, the first serology tests have arrived just recently. And we are going to do a big seroprevalence survey in Israel. We are going specifically to look also at Bnei Brak, which had a tremendous outburst of COVID-19. And we are going to look both at the patterns of how the infection goes from one person to another. We are also doing some genetic tests for the virus to learn where it came from and where it is going. Now, obviously, we have questions that we have no answers to, like how long does immunity last? Because we have heard that some patients have had recurrences, whether these are real recurrences or not. So far in Israel, we didn't see any recurrences. And the question, obviously, whether it can be reinfected. Next slide, please. I think if you go back 2 or 3 slides, you can, yeah, right, that's it. No, that's it. The next one. The next one. Right, no, yes, no. Okay, the next one. Go further. Next one. Okay, this is jumping. Go to the children, because we love children. And one of the big questions is what is the role of children in this infection? Are they being infected? Are they infective? We know that they are. We did a big survey in Maybach. We found out that they are less infected than grown-ups in about 50%, and they are less infective, also in about 40 to 50%, which is significant, but we don't really know whether they are innocent bystanders or vectors of the disease, because they are living in very crowded circumstances. So we are doing this big survey, and this will actually create our policy concerning kindergarten, schools, and playground. And that's by knowing what's the seroprevalence, we'll know how to deal with these little monsters of ours. Next. Spoke about the immune response. The next question, next slide, is concerning the infectivity. Then the question, next slide. The question is when and how long are we infected? When does it start? We found out that at least in our view, people are starting to be infected about 3 or 4 days before their symptoms arrive. I think this is also known from other places, but this is a very concerning issue, because during these 4 days, people get around and actually may infect other people, and that's why we need to cut short the infection circle. And when do we stop being infected? Many of these convalescent people who are being stationed at home or in hotels or in hospitals, we actually release them after having 2 negative PCRs. And sometimes it takes for 3-4 weeks and they have positive PCRs, and we don't really know whether they are infective. So what we did is actually took those PCRs, sent them to the Biological Institute to see whether they are infective. And the preliminary results is that many times the RNA is positive and they are not infective. So we'll learn something about when we can and should release these guys. Next slide, please. Next slide, thank you. We don't know whether we don't know whether this enigmatic virus has seasonality. We know influenza does. And influenza usually drops between 25–30% during the hot season. We don't know whether this will happen in COVID, because this is new for us, and that's why we don't know exactly when we should or should not expect the second wave. We don't know whether there are mutations, but what we see from the genetic work that we are doing, that there are not many mutations in the areas which are considered to be in the infected or the antigens which we are looking for. So this is a pretty stable virus. That's what it seems.
On n'entend rien.
It is, well, it's considered to be a droplet transmission, though in hospitals we treat them in coronavirus wards as aerosolic transmission. But in public, there is a big question: what should the prevention actually deal with? We have the masks. And if you look at the people walking on the streets, well, the masks aren't doing a very good job, because usually what you see is they usually put them below the nose or sometimes below the mouth. And they feel that they are very, very inconvenient. So I don't know what will be the role of masks. And for children, it's extremely difficult. For elderly persons who actually, well, they took away half of our faces with those masks. So people who are hard of hearing actually cannot read lips. There are a variety of problems, and what we are looking for is an alternative which will be kind of a visor, which gives you good protection and yet is translucent, and maybe elderly people will be able to go out and be with everybody around. The question of gloves came up, and it is our recommendation of this council that I'm heading, that gloves should not be worn in public. They usually gather more dirt and more infection than just washing hands with soap and water. So we do think that this is a right thing. We don't think that there should be much decontamination, especially not with very strong agents around. And we actually make people clean with soap and water, which looks like is sufficient. So we are looking at this aspects, and we looked in laboratories to see how long the virus is actually viable on surfaces. It's a pretty short time, basically. And even if it's longer, we don't have many cases that we can prove that have been actually infected by touch. There may be some, but not really many. So next slide. Next slide. Okay, so the question is, where are we going to, and what will the world look like tomorrow, and how will we look at it, whether through visors, with masks, or without? It's a big question. Thank you.
Merci. Alors, beaucoup d'informations dans la présentation du docteur Boiselev, et je vais en garder quelques-uns. Il nous a parlé des problèmes de protection et des difficultés pour les masques, notamment les masques on sait que les enfants sont souvent très mal portés, et les enfants, c'est très très difficile pour les enfants, pour les personnes âgées aussi, parce que ça les gêne pour entendre, puisqu'ils ne peuvent pas lire les lèvres, et il y a probablement des travaux pour essayer d'avoir des masques translucides. En revanche, ils ne conseillent pas de mettre de gants en pensant que ça peut faire plus de mal que de bien, et qu'il y a finalement peu de cas déterminés par transmission par contact. Il a beaucoup parlé des tests sérologiques, et bien entendu, il y a des questions auxquelles il n'y a pas de réponse. Combien de temps va durer l'immunité? L'une des questions, c'est de savoir combien de temps on reste contaminant. Et son impression, c'est que beaucoup de gens qui sont contaminants et qui ont encore des tests de portage positif après une quinzaine de jours, au bout d'une vingtaine ou 25 jours, sont souvent des tests de portage de fragments de ARN, mais ces gens ne sont pour l'ensemble pas infectants. C'est très important pour avoir la durée de la quarantaine. Et enfin, et je terminerai là-dessus, ce sont les enfants. Ils sont en train de développer actuellement des tests sérologiques, et de façon à pouvoir bien vérifier le rôle que jouent les enfants. Ils savent que les enfants sont moins souvent infectés, 50% moins souvent infectés et moins souvent infectants. On ne sait pas à l'heure actuelle s'ils sont simplement s'ils sont des transporteurs potentiels ou pas. La caractéristique essentielle du coronavirus, il a insisté dessus, et ça c'est très très important à comprendre, c'est que contrairement aux autres coronavirus, les gens sont contaminants dès 3 à 4 jours avant les symptômes, ce qui n'était pas le cas des autres coronavirus et ce qui est la différence finalement, la différence essentielle. J'ajoute pour terminer que nous avons actuellement des éléments et notamment les découvertes récentes sur les anticorps monoclonaux contre le coronavirus, et nous avons des éléments qui nous font penser qu'il y a effectivement que les anticorps neutralisants sont présents, et donc il y a plutôt des perspectives optimistes en ce qui concerne l'immunité, et que la plupart des cas de réinfection ne sont pas véritablement des cas de réinfection, mais simplement des cas de tests faussement positifs. Voilà. Je vous remercie et nous allons laisser maintenant la parole au dernier intervenant. OK, so the floor is yours. OK, donc le professeur Lapaz.
Très bien. Merci bien à tous. Bon après-midi à tous. Je continue en anglais parce que mon français c'est pas très bon. Good afternoon all. I'll now try and switch to my presentation, and I'll do it from my computer. It will be a bit easier for me. Okay. So I'll try to summarize the clinical response in Israel very briefly because we're a bit late. I'll just review a few of the things that have been done in Israel. There's plenty more that have been done. One can also use critics, but this is not the main purpose. I think overall Israel done well, and we need to emphasize what was done very nicely. So the initial steps, as Boaz Lev suggested, I call it a bit differently, the team that he heads, the National Epidemic Control Team. And I think they start to convene back in January, and that was a very important thing because there's plenty of infectious diseases, epidemiologists and administrators over there that can create the right atmosphere for responding for a team. And this team is quite old in Israel, and Boaz probably can describe a bit more the history of it, but I think that the fact that it's present and it has a history and it has a mission is very important and very pertinent to what happened in Israel. And one of the major things that they've done at that stage is to define a clinical center for the treatment of COVID-19, and that was defined to be Tel HaShomir. The other issue that fell as a fruit in our hands is the mission that was sent to Japan. We had few Israeli patients over there on the Diamond Princess over there. Few of them were COVID-19 positive, and the Ministry of Health decided, I think in a very wise way, to send a mission over there. And the mission included two physicians. One is the Deputy Director of the Ministry of Health, Professor Itamar Grotto, who is not here today, and myself, and I gratitude for that. And the team over there had few missions. First, to repatriate the Israelis from the ship back to Israel, and I have to say we were with the help of the embassy over there, very successful. Israel was practically the second or third country to repatriate the Israelis from the Diamond Princess. And another mission is to liaise with Japanese doctor on the 4 patients, COVID-19 positive patients over there, just to learn and make sure that they get a good treatment over there. To meet with other teams on practice and diagnostics and the clinical management of COVID-19. While on the morning we were working with the embassy and stuff, in the evening we spent time with physicians and people from the chief laboratory or the main laboratory, the Japanese Ministry of Health laboratory, just to learn what they do over there, how they change their practice and what they have created to serve for the COVID-19 epidemic. And on that time, we need to remember there were about 1,000 patients in Japan. 700 of those were from the Diamond Princess. And then to coordinate the data back to the team in Tel HaShomer on a daily basis and also to the Israeli lab. And I think that was quite important because that helped some of the preparations back in Israel. And this is just a CT from one of the patients over there. In fact, it's two patients. One is a husband and a wife. Both of them were positive. They were very, very mild cases with, you can see only the subpleural infiltrates, nothing more than that. You can see in each one of the CTs the infections. In fact, such patients today in Israel would be treated probably either at home or at the hotel, but on that time, patients like this were admitted in Japan. The other thing that we learned from them is how to conduct contact isolation and what type of precautions being used. Those are the Japanese friends practicing in different departments. This is one of the hospitals, very peripheral hospitals south of Tokyo in Yokosuka. And this is from the Setiyama hospitals, the main military hospital in Tokyo, in which they practiced over there 100 COVID-19 patients in a single ward. Obviously, at that time in Israel, there was no positive case, and it was kind of important to understand how they behave, how they coordinate the inside on the outside. You can looking on those specific phones that they use for coordination and communication between inside and outside to know how to manage such thing. And there was a debate on how to use the PPE, and those are the Japanese samples for that. And this is that just the pictures of the buses coming to the airport in Tokyo for the repatriation of the Israelis, and just to know how the staff was using PPEs to prevent infections within such transfers. Then at that time, the same committee with the committee from Osnat Luxembourg department, they set an MO8 authorization to use medications. I think way before many countries done that, they looked in the literature and searched for drugs that might be relevant for COVID-19, and they authorized an emergency use for those. And this authorization included, for example, hydroxychloroquine, Kaletra, interferon, remdesivir, favipiravir, and IL-6 receptor. And few of those drugs at that time were not even available in Israel, but they started the process as that. And they also set a very fast IRB National Review Board for COVID-19 studies, just to enhance the accessibility of patients to those drugs and to clinical trials in order to prevent a delay, which enables a very fast access for patients to drug that could be available only on clinical trials. Within the Israeli Infectious Disease Society, there was also some response. The society created a communication to create a fast idea exchange and also to debate on different approaches. At least 2 WhatsApp groups within the Israeli society created. One was for severe patients, the other was for the general directors group in order to convey other missions. And what was done over there is protocol sharing initially from abroad. We have used or adopted protocols from Japan, Korea, Belgium, USA. Wherever there was a protocol, we shared it and we implemented part of it upon critical review. There was also sharing and debate on new studies and diagnostics. And obviously the Israeli Society of Infectious Diseases also supported the Ministry of Health mission on joining the Solidarity trial, It was approved just recently, so I'm not sure we'll be able to recruit any patients for that, but that was a very big task for both MOH and Israeli Society for Infectious Diseases. The other thing, and medical students were mentioned over there in France. So a medical student, when taking out of vacation or forced vacation from the school, but what was done in Israel then, because there were free students, they had some knowledge in medicine in mid-March when we understood the need for testing. Those students, 1,800 of those, were called to volunteer under Magen David Adom, the Israeli EMS. They were educated for using PPEs and how to use them properly and how to take swabs properly. And what they've done, what was done, that those students went into people's houses to sample those for COVID-19 to bring the samples into the lab in order to facilitate the testing and make it very easy. And the other thing, since you had to grow capacity, there was a similar mission in which MOH and volunteering organization recruited PhD students to build a lab personnel to enable those excellent numbers of tests that were used during the time for testing and increasing capacity. And you see over here, the students well-dressed in COVID-19 dressing over there. I'm not getting into what is the minimal dressing needed and what so forever, but at least initially, it was obvious that the most protection is needed. And you can see that they have the complete shields, the face shields, and the masks. And here they use double mask, but the N95 or equivalents were used. And other things that were done in order to facilitate knowledge is plenty of Zoom-based seminars with the WHO. The Deputy Director, Bruce Aylward, was with us, and there was also seminars with other countries who had this disease before us, just to learn from those how they dealt with the disease. Seminars were with both China, Italy, USA, and other locations, and some of them were also topic-based. ICU guys went to ICU-specific seminars, ID guys went to ID-specific seminars, just to build up capacity and knowledge. Since we were lagging behind the world, we could learn from others and how they dealt with the disease. Obviously, in each hospitals, protocols were built. Most of the protocols were adaptive and changing with time. I just bring here the Hadassah protocol, but each hospital has somewhat similar protocols, which were based on assessing severity, dealing with anti-COVID-19 treatment. And I can touch with that in a second to deal with complication and when to give anticoagulation. And in few of the hospitals in Israel, hydroxychloroquine was used as the base for the more severe patient, and other treatment were built on that. Since it was approved by the authorization of the MOH, you could start the Plaquenil without a clinical trial. And I think that might, I'm not sure, maybe I'm biased, have helped a bit to improve patient situation. I'm not really sure about it. And obviously some of the studies, one of them is from France, will help us to understand what is the real role of Plaquenil, which is debatable in the literature, but I think all overall has probably some role on that. There were plenty of clinical trials in Israel. There was the Actema tocilizumab trial, the Kevzara of Sanofi. There's a trial with that in Israel. There's a compassionate use study of remdesivir in Israel. There's a use of selenixor, which is an Israeli drug, initially intended for multiple myeloma, but now found to be also effective against COVID-19. I'm not sure how many patients in Israel were enrolled, but I think the study also exists in France. We initiated a study with favipiravir, which took us a lot of effort to get out of Japan. We had a contract with Fujifilm with help with a lot of people from the Foreign Ministry, Ministry of Health, and many others. And I think we were the first country to get favipiravir out of Japan to test it in patients. I think there's a similar study going now in France, in Bordeaux. There is a big study of convalescent sera, also supported by the Ministry of Health multi-center study. There's few centers that try chemostat, nefamostat after the 2 Cell papers. And obviously there's 2 studies on how to prevent COVID-19 in exposed patients. All of those are going on. There's a few more going on. And I put just a solidarity down below because the process hasn't finished yet, when I'm not sure that in the current situation we'll be able to enroll patients to this study. What is the clinical situation in Israel? This slide is partially in Hebrew, but I'll walk you through it. This is the clinical presentation. And since there's a lot of testing in Israel, you can see that the portion of people with symptoms is less than 50%. It is this green and light blue. This is the symptomatic patient, but only this portion, 25%, are patients with fever and other clinical signs. The rest are without fever or without any clinical sign, 40%, and 21% are with clinical sign but without fever. You can see the distribution according to gender. Blue are males, green are females, and you can see the distribution that in Israel there's a bit more males, but the distribution in certain age groups, ages here, can differ between the genders. And when you get into the more severe patient, which is just here on the left, you can see that when you get to the severe patient, then the proportion of males is really higher compared to females. And that's true for almost all age groups. When you get to the rough numbers, then total number of cases, as was mentioned in Israel, is just above 1,600. Those are yesterday numbers, with a total number of deaths of around 240 cases, plenty of tests. And if you compare that to the numbers in France, as was suggested, in Israel, the population is about 90 million. In France, the population is about 60-something million. So just multiply Israeli number by 7, and you can see the differences between the countries, which are, I think, prominent. And the most astonishing numbers or differences in numbers are in the number of tests per million population. In Israel, it's close to 50,000 tests per million, while in France, it's only 16 or 17,000 per million, while France was way ahead of Israel within this epidemic. And obviously, the death rate per million in France is more than 10 times than Israel. Where do we stand now? It was already mentioned before by Ray Singer. We now on the very end of the first curve of the epidemic. We hope not to have a second curve, but obviously we don't know that yet. So in Israel, in this situation is in a good place. There was plenty of initiatives regarding masks, and when it comes to the population, Dr. Boaz-Lev mentioned, but there's also some other initiatives. I know it's in Hebrew, but there was some initiatives from private organization or governmental plans to do that. And this is one of the major initiatives done by Rafael, the plant that deals generally with missile technology. So this plant became with the issue and came out with a cloth, multiple use masks that could be in the quality of paper mask or not, or even better than that. And they created an initiative with the support of Ministry of Health and other ministries. And I just want to summarize with the WHO director, Dr. Tedros Adhanom Ghebreyesus, that this epidemic gave us the opportunity to come together as one humanity, to work together and to learn together and to grow together, as similar as what we do now in this conference. And I would like to thank you all for the attention. This is the Diamond Princess from the main road between Tokyo and Yokohama. You can see it just behind the bars. And I thank for the Ministry of to give me the opportunity to go over there to implement some what I learned over there here in Israel. And thank you very much for your attention. Merci beaucoup for your attention. Thank you very much.
Merci beaucoup, professeur Nirpaz, avec une présentation passionnante qui a montré les caractéristiques de la réponse israélienne. Alors, je vais essayer de le résumer très vite. Premièrement, constitution très rapide d'une espèce d'un groupe de contrôle sous la direction du professeur Boazlev que vous avez entendu, d'un groupe de contrôle national sur l'épidémie dès le mois de janvier. Ensuite, rôle très important de l'équipe qui a été envoyée au Japon pour analyser la situation des Israéliens qui étaient sur ce fameux bateau, le Diamond Princess, et ce qui leur a permis de voir comment le Japon réagissait en matière de prophylaxie et de prévention pour les gens qui étaient touchés par le coronavirus, ce qui a été ensuite transféré en Israël. Troisième élément très important a été la réactivité du ministère de la Santé, notamment du département des technologiques, dirigé par des médicaments et des technologies, qui est dirigé par ma cousine, Dr Osnat Luxembourg, et qui a autorisé très rapidement, qui a mis à disposition une quantité de drogues, de médicaments dont on pouvait penser, d'après la lecture, qu'ils pouvaient avoir une efficacité sans qu'on en soit sûr. Parmi eux, l'hydroxychloroquine, mais pas que, remdesivir, etc. etc. Ensuite, les contacts qu'il y a eu entre tous les intervenants en matière de pathologies infectieuses qui ont réalisé à l'intérieur du pays des groupes sur lesquels on partageait les informations, on discutait, des groupes WhatsApp tout simplement, ce qui a permis une très très grande souplesse de réaction. Le rôle des étudiants. Alors les étudiants en médecine ont été en partie utilisés pour effectuer les prélèvements, chez les patients directement. Ils sont allés avec toutes les précautions nécessaires, mais c'est eux qui ont fait une grande partie de cette grande quantité de tests que les Israéliens ont pu faire. Et enfin, les webinars organisés par Zoom avec divers autres pays comme l'Italie, comme la Chine et comme les États-Unis. Donc, à partir de là, il y a divers protocoles. Il nous a montré le protocole de sa maison mère, qui est à Dassa, mais il y a eu d'autres protocoles. Je souligne aussi que le rôle particulier qu'a joué l'hôpital de Tel HaShomer dans l'organisation de la réponse au coronavirus. Ils ont utilisé en particulier l'hydroxychloroquine aussi. Il pense que c'est plutôt un peu positif, sans qu'il en soit véritablement certain. Ça n'a pas le caractère que ça a eu en France. Enfin, cette façon de tester les patients leur a permis de montrer que plus de 50% des patients ne sont pas vraiment symptomatiques. C'est-à-dire que 40% des gens positifs n'ont pas de fièvre, 40% ont de la fièvre mais pas de signes cliniques, et 20% ont des signes cliniques sans fièvre. Et enfin, dernier point, et je m'arrêterai là, les formes graves. Les formes graves sont très souvent des hommes. Il y a un peu plus d'hommes que de femmes qui ont la maladie, mais il y a surtout beaucoup plus d'hommes que de femmes qui ont les formes graves de la maladie. Enfin, pour terminer, quand même, les problèmes, disons, les améliorations technologiques, par exemple, Raphaël, l'industrie de haute technologie Raphaël, que chacun connaît, et qui travaille sur des masques particuliers. Et donc ça, c'est la souplesse de l'industrie israélienne. Alors, ils ont fini la première vague. Ils se préparent à la deuxième vague, tout en espérant que cette deuxième vague n'aura pas lieu. Merci. Alors, nous allons maintenant, je pense, laisser la place aux questions, n'est-ce pas, Alexis?
Oui, tout à fait. Oui, tout à fait. Nous avons eu de nombreuses questions. We had a lot of questions. So we are here with Professor Nirpaz, and most of the questions are biologic or maybe concern Professor Nirpaz. La plupart des questions sont plutôt d'ordre biologique ou d'ordre très médical, et nous avons la chance d'avoir le professeur Nirpaz. Alors, la première question est très simple, elle est posée par un de nos collègues de l'AMIF, le docteur Pierre Tachefel. C'est concernant les moyens de protection, masques, gants ou lavage de mains. Selon vous, quelle est la mesure la plus importante? The question is from our Dr. Pierre Tachefel. It's about protection measure. For you, which is the main, most important things between the mask, wearing a mask, washing the hand, and or the other protection? Can you answer this question?
I think the answer is both. Washing hands is extremely important, and putting masks is important. Each one is for a different reason. Putting the mask is protecting yourself from a person that is infected around you, or protecting the person around you if you are infected and you don't know that, just in the pre-symptomatic phase. If you just put surgical masks, then if both sides use surgical masks, then the protection is about 90% protection. If you use a better mask, then the protection is better. But it was calculated that surgical masks on both sides probably is enough to reduce immensely the amount of infection. Washing hands, we don't know what we touch. The more we wash our hands or use alcohol rubs, that's the way to go. It helps us in preventing, if we don't pay attention, we generally go and touch our face, touch our glasses, touch our heads or something. The more we clean our hands, the better we protect ourselves. The virus gets into the oropharynx or through the eyes or through the nose. And the more we protect our hands, reduce the viral load on the surface that we touch. From the surface that we touch, we protect ourselves. So social distancing, masks, and alcohol rubs are probably the best way to go and to practice.
Thank you very much for this clear question. So there is another question. I try to sum up the question because there is a lot. Il y a plusieurs des questions que je vais essayer de regrouper. One of the questions is, for example, we at the AMIF, our association, we organized a congress in Tel Aviv in May. It was cancelled. And by the way, we will be glad if you come for the next edition on 2021. But we have a question for French people who have planned holiday in Israel. A lot of people have canceled their vacation for May and June. And I know that it's difficult to predict the future, but what is your feeling about the August and July months for French people to come to Israel?
Maybe Roy will be the right one to answer it. Roy Zinger?
Yes. Yes, please.
I'm sorry, Roy is not with us at the moment.
So Boaz, maybe Boaz Levy can answer that.
Yes.
Sorry. Yeah, well, it's like being a prophet, and I haven't those skills because one of the things that we may be viewing is maybe another burst, another peak of COVID-19. We don't know. We just now are opening our lives and going out, and the schools are starting. So it's very, very difficult to say. And as I said before, we don't know whether there is seasonality, whether we'll see a real dip in the activity of the virus. And at this point, the heavens are closed. So there is no communication. Basically, if somebody comes to Israel, he has to go into quarantine for 14 days, which is very cumbersome, very difficult. So at this point, it's very difficult to say, and I think we'll have to wait for another few weeks until we can say what's going to happen towards the midsummer.
Perfect. Thank you very much for your clear and precise answer. So I understand it's difficult to say, to predict the future, and thank you for your answer. We are lucky today to have another friend of AMIF, it's Professor Philippe Alphon. Nous avons la chance d'avoir parmi nous le professeur Philippe Alphon, which will present himself, and you have a specific question maybe for Professor Ran Nirpaz. Philippe, tu as la parole. Présente-toi, s'il te plaît, avant de... Merci.
Hello, everybody. Good morning. I'm Philippe Alphon, and I'm an infectious disease based in Marseille, and I'm a professor of medicine, very close to Hadassah and to Tel Hashomer also. And first of all, I'm very proud about the different management measures that you are taking, like early closing frontier, the screening of patient and isolation, and the management of close contact. I'm very impressed by the 1.2 days to isolate the close contact, and how much a different policy in each country can conduct for a different disaster or success in terms of number of died people, that we can observe the difference between France and Israel. So I have two questions, and the first one is a clinical question. Right now we have a concern with this COVID-19 about one of the delay complications that we observed in some patients with lung fibrosis that we observe even in moderate or in mild symptoms in some patients. I would like to know what is your feedback or your observation. And the second one is a different question. We know how much Israel is an innovative country that we are all very proud. We know, and we have a lot of announcement effect about new treatments, new vaccine, and new diagnostic assay. But at the end of the day, on the coronavirus, what will be the most advanced innovations that you can right now tell for all of us that we are proud and sure?
Okay. Boaz, would you like to start, or?
Yeah, I'll start, and you'll. Well, one thing that we are doing currently, and I think many places in the world are doing it as well, but we hope to to have some advances, is actually taking convalescent plasma from patients who have undergone the infection, and we are actually measuring the antibody levels. We're using Euroimmune kits from Europe, from Germany, and they're very sensitive, and actually we take those with high titers of antibodies, and we use them at this point. We give plasma to patients who are not severely infected. Some of them are severely infected, but we think that it should be given prior to going into the severe stages of the disease. So this is one thing, and results seem to be, it's difficult as long as we don't do it in a fashion of a clinical trial. And we started the clinical trial, so hopefully in some time we'll know whether this is helpful or not. This is one thing. The other thing is we are trying to, we'll do some purification of immunoglobulin. And as some of you remember that before the hepatitis A vaccine, we used to give passive immunization to people prior to exposure or immediately post-exposure. And we do hope that this immunoglobulins will be helpful in actually maybe preventing, and if not preventing, maybe helping to patients, because we don't really know what the role is of humoral versus cell immunity in the disease. Probably both of them play a role. So this is one thing. As I mentioned, there are some efforts to purify antigens in order to make vaccines, and that's something that everybody is working on. But we have here at least 3 or 4 groups doing that. Maybe, what do you think, Ran? Can you add some things that?
Okay, so I'll do it just the opposite way, but let's start with the innovation. So when we had the discussion with Bruce Aylward back, I think almost 2 months ago, and he said to us that he's looking forward to what we are going to invent with this disease. And I was, thinking for myself, everybody's doing everywhere a lot of things, and everybody has plenty more patients than us. So why should we innovate? Everybody is so much ahead of us. And then I learned with the disease that, and the way that the country behaved, and the way that many groups volunteered to help the ministry and to create a working atmosphere, which was not available anymore, and to create an infrastructure that I think will be copied for more epidemics to come and to learn from. So our innovation, I think, was in many ways in the organization, recruiting the industries and military organizations into creating an infrastructure to close the gaps on diagnostics, to close the gaps on masks, to close the gaps on equipment, and to close the gaps on drugs. And while everybody is fighting for those, you need to know how to get those. And I think this is a type of innovation which was important. The other innovation is not really innovation, it's just to learn to use simple measures to reduce infectivity, to remember that masks, washing hands, and social distancing and lockdowns is probably your best bet and the most effective measure when you don't have any other measures. And that's what created a big difference, I think. There's plenty of other small things, bigger things, more innovative, less innovative, but I think those are the two innovations. There's plenty of work done by Israeli physicists modeling the disease. I think none of them was copying the models that were used by the UK or other countries, and that helped both Ministry of Health and other organizations working on prediction and preparing in getting the right decision along the way. And with regard to your first question, the lung fibrosis, there's not much report in between the Infectious Disease Society about that. At Hadassah, we had more than 400 patients, I think, at this stage. I think that if we'll see that is with those ventilated patients that were ventilated for 20, 30 days. The rest, almost none came back readmitted, and the very few that came back readmitted, none of them was for respiratory issues. So I'm not sure that we saw that yet. Probably there is, but I think the fact that we are in many ways behind you in time, maybe is the reason that we haven't seen that complication yet.
Thank you very much.
Thank you very much. Maybe we have time for the last question.
I would just want to add a few more things regarding the innovation. First of all, you have to know that there's a lot of data sharing and a lot of cooperation between the regulatory agencies all over the world. And we're trying to build fast track for innovation regarding the COVID-19. That means, for example, that every 2 weeks there's a conference call with FDA and EMA and other regulatory bodies to see what is the status of the vaccination or other drugs that are being under clinical trials. So the information will be shared, and all the regulatory agencies will be able to act very fast when things will happen. So this is one thing regarding innovation. The other thing is that in Israel, we found that the interdisciplinary work that has been done with the military and with other groups from the academia and from the health system emerged a lot of innovation. We have more than 1,000 different ideas that are being tested and we're doing also a technology assessment to all of them. Some of them are moving forward to go into clinical trials or to go into the industry or to meet the demands or the needs of the staff in different hospitals. And some of them are for long term. But things are moving and it created a lot of ideas.
Thank you very much.
Thank you very much. Maybe we have time for last question and then we have to conclude this session. The question is maybe we answered it a little bit before, but it's about, we know that artificial intelligence experts and intelligence services like Shinbet in Israel are among the best in the world. We know in France from media about their involvement in the control of epidemics in Israel, especially concerning contact tracking application. In France, we have a project called Stop COVID, but it's not launched for liberty issues like individual liberty. Do you think that this technology can explain, at least in part, the success of Israeli response? And do you have any advice for France on their place in the deconfinement strategy?
Well, I'll try to answer that. We think that about a third of the cases, the contact tracing revealed about a third of cases that wouldn't have been traced otherwise. So from the medical point of view, I think it's definitely was working, but the liberty parts of it are very problematic. We have currently extended the use of it, but there is a lot of controversy in Israel. So it's only one of the big controversies in Israel, as you know, currently. There's some other ones as well. So. Okay,
thank you very much. Maybe Richard, you have something to say to conclude this session?
Well, I have to ask all the people who were involved in the preparation of this meeting and all the people who gave those lectures. They were fascinating and they were really, tell you the truth, very extremely interesting, because they gave us the opportunity of feeling what the specificity of Israel is. That means the agility. The agile country, small country, and we have been loaded by our bureaucracy in some way in France, and we see that you are able to meet together, to change views, to go on out of the road, and that means all these very specifically cultural principles have certainly a lot to do with the success that you have in controlling the coronavirus epidemic. So thank you very much. We all hope that you will not, and we will not have to face a second wave, but I think we will be very pleased to have at least a second wave of discussions with you at another time. Thank you, all those who prepared this meeting. Goodbye.
Thank you.
Thank you very much. This webinar is over. The replay will be is already available on Facebook Live, and will be also available in full version on AMIF website very soon. Once again, we like to thank you, our speaker, and thank you very much. Mesdames et messieurs, le webinaire est terminé. Nous vous remercions d'avoir été si nombreux. Le replay est déjà disponible sur Facebook Live et le sera très prochainement sur le site de l'AMIF. Je remercie à nouveau l'ensemble des conférenciers pour cet échange. Merci beaucoup et à très bientôt.